This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I bring you my conversation with Jo Gibson to discuss the shoulder and the steps to success. During our discussion, Jo will talk about the role of special tests, what to look for in the assessment, the role of imaging and when to refer out, improvement tests and how they guide treatment, the influence of the kinetic chain on shoulder pain, the next influence in shoulder conditions, assessing and managing shoulder stiffness, tears, and irritability, and much more. Jo Gibson is an Upper Limb Rehabilitation Specialist at Rehab for Performance in Liverpool, UK, and an Honorary Senior Research Fellow at Liverpool Hope University. She previously spent 27 years as a Clinical Specialist Physiotherapist in the Liverpool Upper Limb Unit. Jo is an expert in shoulder rehabilitation, regularly lecturing, co-authoring guidelines, and publishing research. She also consults with elite sports teams on shoulder injury recovery. If you find our conversation informative, I encourage you to subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who could benefit from our insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PT Pro Talk for a special offer. Hi, Jo. Welcome to PT Pro Talk. How are you today?
I'm great. Thanks so much for having me.
I appreciate you coming here. And so let's get started talking a little bit about yourself and your background.
Sure. So my name's Jo Gibson. I currently work as an Upper Limb Rehabilitation Specialist in a clinic called Rehab for Performance in Liverpool in the UK. And I've been there for 3 years now. Until about 2 and a bit years ago, I worked as a Clinical Specialist Physiotherapist in the Upper Limb Unit, Liverpool Upper Limb Unit, and that's a job that I'd done for 28 years. So specialised in helping people with shoulder pain and instability, and built up a team there that I'm incredibly proud of, and they've now carried on all the great work since I've left.
Awesome. So 20 years of experience treating shoulders?
Oh, nearly 30 years now. I'm getting very old.
That's awesome. So we have a lot to learn from you. Great. So I was telling you just before we started that I watched a few series of your webinars on like the shoulder assessment. I thought it was very interesting. And I know the first one you discussed a lot about the special tests. So what is the role of special tests in diagnosing shoulder conditions?
Oh, what a great place to start. Very controversial. So yeah, I think over the last probably 10, 15 years, there's been a whole shift away from a very biomedical model to much more of a biopsychosocial one, to really reflect that we have more and more evidence that really challenges the link between structure and pain. And because of that, it's really called into question some of our special tests. So I think when we look at assessment generally, one of the most important things is that 80% of our clinical decision-making or diagnosis is based on our subjective assessment. So by the end of hearing somebody's story, I really should be pretty confident I know what the issue is and how that's going to impact my treatment. And then, if you like, my assessment is the 20% that confirms or negates that hypothesis. So when I look at my special tests, one, I think a lot of our special tests really aren't that special. And secondly, we need to ask ourselves the question, what are they trying to tell us? So if we look at a typical subacromial pain patient, and we look at a test like Hawkins and Kennedy impingement test or near impingement test, those tests really don't have any clinical utility because they tell us what we already know is that the shoulder hurts. But if we do those tests and it's painful, they don't tell us whether it's the bursa, the AC joint, the cuff. It really doesn't tell us anything different to somebody telling us they've got a painful arc. It hurts when they load it and it might hurt when they lie on it at night. So when we look at things like those pain provocation tests, I would agree they don't have any utility. However, the other big limitation of special test research is it generally takes a group of patients between 18 and 80 and applies the test. Well, if you don't have the subjective history, that special test is useless. Whereas if I use an example of somebody who's under the age of 25, they dislocate their shoulder, somebody has to put it back in joint for them, and they say they feel apprehensive. If I do an apprehension test and it's positive with all those factors, then they're 85, 90% likely to have a labral tear. So some of our special tests, our apprehension, our instability test, and some of our rotator cuff tests with a relevant history do have utility in guiding our clinical decision making, but they're a tiny part of the whole story.
Okay. And so do you think it's important to diagnose the source of the pain? Like the specific structure in the shoulder? Is it important? Is it not? What do you think?
So again, it's very dependent on the patient cohorts that we're looking at. So if I look at a typical group of non-traumatic shoulder pain that don't have any worrying features in terms of red flags or things that don't fit the picture, I'm very clear that it's just a non-traumatic subacromial pain, either a bit too much load or maybe not moving the shoulder enough. In that situation, this move away from terms like impingement is one to reflect that the pathology is no longer supported, i.e. this pathological top-down model where something rubs on the cuff. We know that has no evidence now, much more about what's happening to the structures within that surface. But as you quite rightly kind of intimate, whether it's the AC joint, the bursa, the cuff, doesn't matter, because if we look at studies that have tried to stratify those patients, it makes no difference. If we apply the same principles of treatment, irrespective of what we might see on a scan that probably isn't that relevant anyway, 80% of patients respond to the same key things. So initially, somebody who presents with subacromial pain, it has a very clear mechanical picture, a very clear aggravating and easing pattern, then knowing whether the AC joint, the bursa, the cuff is not supported at the current time. And as we know, lifestyle factors, comorbidities, psychosocial factors have probably more role in the relevance of pain sensitivity and how somebody will improve. Now, it's a very different story potentially in somebody who's had a clear history of trauma or potentially has done sport or heavy loading for a long period of time. Because yes, we will see in overuse and high load populations, we'll see structural pathology. It doesn't mean they've got pain, but by the time they start to have problems, if they're not responding to our interventions, then it might become more relevant. But I think where it's really relevant to consider is if somebody has had a clear mechanism of trauma with immediate onset of symptoms and those things aren't changing or getting better over time. And that's where putting the story together with imaging, together with special tests can be very helpful in signposting patients that surgery may be an option.
Okay. And since you're talking about the surgery and trauma, so when do you decide to refer out a patient? When do you think that what gets your attention to like, this might need some, set of eyes looking at it?
Yeah, again, really good question. And there's, as ever, lots of things that influence my decision making. But let's say I have a young patient who's under the age of 25. They come to see me. They play sport at a high level. They had a dislocation. It was relocated. And they're still apprehensive. And it's very positional. So in the position they dislocated, if I put their arm there and I do an apprehension test, it's positive. I know there's a high likelihood of structural damage, but that on its own doesn't mean that they need surgery. So again, when we look at this is where imaging can be very useful in informing our decision making, not so much in that non-traumatic population because we know the imaging can make it worse, but in this guy who's got high demand and wants to get back to sport quickly, if surgery is indicated, it reduces his risk of redislocation by up to 7 times. So it's got to be in my decision making. But if I do imaging in the form of an MR arthrogram, which is most sensitive for looking for labral pathology, and also will assess any associated bony pathology, so damage to the glenoid or damage to the humeral head, then there are key pathological lesions that we know patients are between 90 and 100% likely to redislocate. So if they've had the right history, they're apprehensive and they want to get back to high level sport, and the imaging shows something that suggests they've got a high risk, then surgery can be a really good option. So if you like, the imaging helps weigh up whether it's worth us trying rehab first or whether we're going to have a lower threshold. But as physios, we're really in the driving seat because the evidence would suggest that pre-op rehabilitation helps the post-operative recovery. So I'm still going to start my rehabilitation whilst maybe I'm waiting for imaging, etc. And there's no doubt in many pathological lesions we see regarding labral tears, people still have potential to rehabilitate. So those patient demands, what they want to get back to, the clear history of trauma, dislocation, relocation, together with those imaging findings, putting all that together helps me help the patient make an informed decision.
Great. And now maybe a tough question, but so like how do you always try to do like clinical first, like rehab, conservative rehab on those cases of patients that have some structural damage to see if you can help them and before make a decision of going to surgery? Or there are some cases that like, yeah, that this person, there is no way they're going to respond to conservative treatment?
Yeah, so again, a really important question, and one that can be quite difficult to tease out when you look at the evidence at the moment. I think in that instability population with high demand, the imaging really helps my decision making. But again, if there's a trend of improvement with rehab, we'd continue. But if I'm problem solving somebody 3 years down the line and I'm pretty clear there's something structural that stopped them getting better with other clinicians, then my threshold would be lower. I think where it becomes murky and harder to make a decision is when we look at our rotator cuff tears. So I think if you have a patient who's under the age of 50, who's fit, healthy, no comorbidities, active, might do sport or the gym or whatever, and they have a clear mechanism of injury with immediate onset of pain and loss of function, so clear weakness and loss of elevation that isn't changing at 6 weeks, and I assess them and they have got frank weakness, 50% of people presenting like that are likely to have surgery. But again, an ultrasound scan will help establish a truly acute tear, or something that in somebody maybe a bit older, maybe not as fit, not as healthy. They've just had a previous tear that's just extended because they've had trauma. Now, in that situation, using my special test, so maybe just doing a full CANS test or some gross external rotation testing is useful. But if it's painful and inhibited, that could just be painful inhibition. I don't know if they've got a tear. But if I make life easier for the arm by supporting it, doing some other symptom modification strategies, and I can make them stronger and less painful, it doesn't rule out a tear, but it tells me I've potentially got an opportunity to rehabilitate them. So I guess it goes back to the example I talked about with instability. In my head, what does this patient want to get back to? Have they got any comorbidities? How healthy are their tissues? And I think with rotator cuff tears, the one group that we have to have a low threshold to consider early surgery is that under 50 healthy, metabolically healthy tissue, no previous history of shoulder pain, wants to get back to high demand, who has clear weakness and pain that aren't kind of changing or improving over that 6 to 12 week after that original. Now, the reason that's important is because the evidence would suggest if they have their surgery within 4 months of their trauma, they'll have the best outcome. If you meet that person 6 to 8 months down the line, then you might as well try rehab first, because by that time, you've got cell death at the edges of the tendon. The potential for healing is not as great. And so actually trying rehab to optimize them, even if they end up having surgery, is well supported. So there's some key things. The time you see them after the injury, the immediate onset of symptoms in response to that injury, and the fact there's no real significant change over time.
Okay, great. And what are you looking for in an assessment?
Again, in terms of my subjective, of course, I'm always trying to pick up a patient's beliefs, their understanding of what they've been told before, any things that they're worrying about. So their beliefs, their expectations, their concerns. Because again, I do a lot of problem solving with patients who've seen lots of other patients, and often it's more to do with communication and that belief system than anything that a clinician's done wrong. But I like to use a really simple clinical reasoning framework. So when I've heard their story, the things that go through my head are, is it torn? So have they got a history of trauma that is significant enough that it might have caused structural damage? So the young cuff tear or the young instability, that might be relevant, but they may have an AC joint instability too. And again, all those things we've just talked about, am I going to think about some imaging, and is it going to reduce my ability to help them? If it's not torn, the next question I ask myself is, have they got a history consistent with a stiff shoulder? Now, of course, there's lots of different causes of stiff shoulders. If it's arthritic, I'm not going to be able to change that stiffness. If it's capsular, are there a frozen shoulder, a post-op, a post-trauma? Or again, is there other things that might contribute to stiffness? Now, again, the reason that's relevant, if we look at the limited evidence that we have, generally, I need about 70% of my rotational range in any direction for my muscle system to be able to do its job through the full range of elevation. So if they have got stiffness and it's not arthritic, so again, if it's bony stiffness, I can't change it. But if it's capsular or muscle stiffness, I can change it. So I might have to target that before I can look at targeting the muscle system. If it's not stiff, the next question I ask myself is it irritable? And by that, I just mean acute causes of shoulder pain. So a reactive tendinopathy, a calcific tendinitis, a developing frozen shoulder. And the only reason that's relevant is if they have very irritable acute shoulder pain, I might not be able to change it with my symptom modification. Because having asked myself those three questions, is it torn, is it stiff, is it irritable, then obviously I do my usual objective in terms of look, move, feel, and resist. But I'm also going to use symptom modification. So my next question is, can I change it? And so I use some very simple principles to look at, can I change their movement that's most painful? And my final question is it strong enough to do the thing that they want to do? So I'm very aware there's no evidence of superiority of strengthening in terms of our interventions, but if a patient wants to get back to a particular level of function, I need to make sure they've got the capacity to do that. So that really is my simple approach. The only thing I missed out there is from their subjective, I guess the very first question is it a shoulder problem? Because again, there's a high correlation, a high percentage of patients that might present with shoulder pathology that actually the problem is generated from their cervical spine, not from their shoulder, but also we can get weird and wonderful visceral referral into the shoulder as well.
Okay, you just said a whole lot, so I'm gonna go by items. I'm looking at my notes here. Okay, we already discussed a little bit about if it's torn, right? When you decide to maybe refer them out, get some imaging, see if they are progressing well or not. So you talked a little bit about managing those patients. Anything else that you want to add towards the observation that you're asking yourself if it's torn, and then what do you do from there? You think you're...
Yeah, I think again, I often see people a long way down the line and they've had an original injury and they kind of improved a bit and then it never got any better. Generally, if you've got something structural that's causing the problem, it will be reproducible in a consistent position. So if it's contractile, I can obviously resist the muscles to test that out. If it's more labral, again, I can put the labrum in a position of tension and test that out. Now, that's great with kind of anterior and posterior labral tears, but superior labral tears, slap lesions, are notoriously difficult to pick up clinically. So it's always going back to the original mechanism and knowing common mechanisms that result in those injuries and the age groups that you're likely to see them in. So probably one of the things I see that is missed, and it's not a common injury, is either posterior labral tears, because often they present with pain rather than instability. And generally they'll give you a mechanism where they've had either fallen onto a flexed internally rotated arm, or they've played a sport where there's been collision that's forced the arm posteriorly. And they'll often tell you it felt like something went, but I carried on playing, but now I've got pain every time I load my shoulder in that direction. 2/3 of patients with proven traumatic posterior labral tears have pain rather than instability as their key feature. So understanding those things just helps you listen for that in the history. And superior labral tears, again, if they're traumatic and somebody wants to get back to high level sport, that one of the commonest things they'll tell you is they just cannot produce force in that abduction external rotation position or in overload positions because they've lost that stability in the top of the joint. But really it's about, did they have a mechanism that puts something structural on stretch? And if I do that same thing, does it reproduce their symptoms or their feeling of instability? And putting all the kind of detective clues together, if you like, to kind of increase your certainty or suspicion, if you like, of a particular diagnosis. But with that mechanism, if they've got a history of not responding to rehab, I think that's where imaging can have a very useful role as long as we put it into context.
And like from the patients you see, just so we can have an idea, do you have like a percentage or a number that you think what are those patients that end up needing surgery that don't respond to like the conservative approach? Are the majority of ones that have labral tear, rotator cuff tear, or not?
So I would say that's a really great question, actually. I would say that collision athletes or high load athletes that have have a true dislocation commonly end up having surgery because the very nature of the sport, the pathology that you see in their shoulder is quite significant. So I would say probably 60-70% of that cohort end up having surgical intervention. In terms of the under 50 traumatic cuff tears, interestingly, I would say probably only 35% go on to surgery, but that's because you're including small, medium and large tears. And we now know we have studies looking at small and medium tears and showing that actually rehab can be as successful. But as ever, it's all those different patient factors, functional demand that go into the decision making.
Okay, great. And then on the stiff shoulder, now moving to your second question, is it torn, then is it stiff? So how do you diagnose if it's arthritic? Is just by the age of the person, or maybe they had a trauma, then it became like that after a while? Like, how do you diagnose that group?
Yeah, so again, great question. I think when we look at, in my head, when I'm looking at bony pathology, the most common things we're likely to see are either going to be your primary arthritis, your post-traumatic arthritis, or your cuff tear arthropathy, where somebody's had an underlying rotator cuff tear that's got worse over time, and then they've developed secondary degenerative changes. Now, you can imagine in that group, they're typically older, over 65. They'll tell you they've had episodic shoulder pain over a period of time. And essentially they start to get weakness and then they develop stiffness. So in their history, there's a very clear progression. But when you look at their range of movement, their external rotation particularly, it's almost like a bony block. It's not the capsular block you'd feel in somebody with frozen shoulder. If I look at a primary osteoarthritis, then again, it tends to be, it starts, it niggles, it's more general ache. You don't have the same episodic history or the development of weakness. Pain is the predominant feature, but with a very typical arthritic pattern of stiffness when not moving, a bit better when they get going, and very diffuse joint pain. Often starts in the posterior joint. But then obviously you've got your post-traumatic arthritis, and they generally will have either had a history of cuff injury or more commonly a history of instability that didn't get treated, so a dislocation, gone back to heavy loading, and then they can present as early as their late 30s or early 40s, but again with a real kind of bony block to their restriction. But because of their subjective history and that really bony stiffness, that's where an X-ray is really valuable in confirming your diagnosis and showing you how severe or not those degenerative changes are. So as ever, that subjective history is key.
And then I imagine this group is hard to change.
Yeah, and absolutely. And that's why it's so important to know what is causing the restriction. So if it's bony and we can't achieve that 70%, if we say to the patient, yay, we can get full range of elevation and we're setting them up to fail because they don't have the range to allow the muscle system to do its job effectively without negatively affecting joint loading. So it just means we might need to have more realistic functional goals in those particular patients. And in some of them, the pain and the dysfunction might be so severe that they decide to pursue something like arthroplasty.
Mm-hmm. Okay. And then that group that has a stiffness due to like a capsular or muscle stiffness, how do you diagnose them?
Yeah, so again, so if we look, I think frozen shoulder is one of the things that causes people the most headaches in terms of diagnosis. So it's kind of, if somebody comes to me after surgery or after trauma and they've got external rotation restriction, then I kind of, it's just, is it isolated stiffness relevant to the surgery or the trauma? So I'd look at rotation through the full range of movement. So external rotation, abduction, internal rotation in abduction and neutral. And somebody with an isolated stiffness, there'll just be one direction of stiffness. Now, in a frozen shoulder, I think if we're lucky enough to see people soon enough, then actually if we can intervene early with an injection, we can potentially reduce that painful phase and potentially the overall recovery. But as you can imagine, most diagnostic criteria say patients with frozen shoulder have to be stiff, that full-blown loss of range before we can diagnose them. Now, if you look at the evidence at the moment, the typical age range is 40 to 60, but the majority of patients are in their 50s. So somebody comes to me in their 50s with a really, really painful shoulder, no particular mechanism of injury. The pain's escalated, it's diffuse around that deltoid region. About a third of patients have referral into the forearm, but that horrible pain, that massive, significant sleep disturbance, quick movements are eye-watering. But interestingly, if you support the arm and resist it, it's actually not that painful because it's not in the contractile tissue. So I kind of put all that together. The other really important thing that the evidence helps us with is that 80% of people who develop a primary frozen shoulder have a risk factor. So they're either diabetic, they've got thyroid, they've got cardiovascular issues, metabolic issues, they might have a family history. And so again, if there is a risk factor in the right age group with the right pain location, pain behavior, then that weighs up or stacks up the evidence. So I become much more suspicious that it's a frozen shoulder. And then that's where my objective assessment can help me prove or negate that in terms of resisted testing and unloading, and importantly, where they get their pain. If they're stiff, it's kind of easier, isn't it? Because they've already got that restriction. But again, have they given me a history that I expect them to be stiff? Yes. If not, it might just be protective. So again, it's putting all the bits of the story together.
So the risk factors are more like metabolic than anything that they do on their day-to-day or any movement related.
Yeah, interestingly, when you look at frozen shoulder in terms of the only thing relevant to movement related, it tends to be in more sedentary populations or people working at desks where they're not regularly moving their arms above shoulder height. But much more of the evidence supports cardiovascular, metabolic, etc. Absolutely.
Okay. And any considerations on muscle stiffness?
So I think, again, the reason I said at the beginning that is it irritable is if somebody comes to me with high levels of pain and very reluctant to move their arm, if I'm not happy, because it's horrible for the patients, but if I'm happy that it's a reactive tendon or a developing frozen shoulder or an acute calcific tendonitis, then I expect them to have high levels of pain. However, if they give me a history that doesn't fit with the pathologies that give them high levels of pain, then that can be an early warning system of somebody with really negative beliefs and psychosocial factors. So then if I look at their rotation and it looks very restricted, I can just put my hand in their axilla, and what you'll often find is they're really kind of clamping or fixing on with their lats and their pecs to try and protect their shoulder. And so that kind of feeds in that this person's a bit scared to move. And so that really helps direct that I need to invest in understanding that story before I start trying to change what's happening at the shoulder.
Okay. And how do you manage the frozen shoulders?
So in the early stages, I think the most important thing for me is an early injection. So it's one time where I have a really low threshold to do an intra-articular injection because I think it is the most supported intervention at the moment. We know that we can have a lot of effect in modulating pain around the shoulder by targeting the neck. So whether it's the patient doing it in terms of repeated movements, us maybe using some manual therapy to augment that can be useful. But essentially, it's getting the patient doing movement where they don't poke the bear or that it's not provocative, but we keep them moving and lots of ways of unloading the shoulder. So either supporting the weight of the arm, using the kinetic chain to initiate exercise, unloading the arm. You can use a kind of strap with TheraBand so they can still do functional movement, but it's very much an emphasis on patient understanding, We know that if patients have a poor understanding and they're scared, and frozen shoulder is pretty horrible, that gives them even more pain sensitivity and even more functional restriction. So the education and reassurance is massive. The injection plays a big part in pain relief, but then I think there's other things we can do targeting the neck and the thorax in exercise and or manual therapy, and generally unloading principles to just get them moving. And that's increasingly supported. Once they're in that stiff predominant phase, it's very different. There's still some experts that suggest we can just leave it alone and let people get better over time. Again, patients seem to really value support due that recovery period. And there's some emerging evidence that there are things that we can perhaps do to influence that stiffness and get them back to functional movement. So I like to use a combination of eccentrics and then kind of working the opposite side of the joint to try and maintain that range, because I think that targets the capsule, and sustained stretching, patients have to do it a lot for a long time to get an effect. So things like eccentrics, they do lower dosage, but can get a very comparable effect over a 6 to 8 week period. So that's kind of where my practice has changed. But I think we have to be honest that we probably need some more evidence to support that. The other thing is, in people with pain and stiffness, there's increasing evidence for hydrotherapy. So getting in a nice warm pool and doing assisted movement and resisted movement within the pool, the kind of proprioceptive input and the damp heat have a really positive effect on the sympathetic nervous system that we know is heightened in frozen shoulder. So again, that gives us some other opportunities in patients that are struggling.
Okay, and I heard you talking before in another YouTube video that I watched, that you use x-rays like in your practice to truly diagnose a frozen shoulder, right? Is that...
So again, that's quite, in the UK, that's become quite an issue that everybody likes to argue about. So I've got two hats. If I'm in, so my job when I was in the hospital, I worked in what we call primary care, which is where the first person you're the first person a patient sees, or where their doctor sees them in the community. And then my other job was in secondary care, which is where they come to see a specialist because they haven't got better. Now, in secondary care, if somebody was referred with a frozen shoulder, we would automatically do an x-ray, because frozen shoulder is the most common misdiagnosis for malignancy or avascular necrosis or more nasty pathologies in the shoulder. So the fact that they've failed an initial course of rehabilitation or injections or whatever, and now they've come to the specialist, our radiologist said, look, the risk of something nasty is higher. You've got to do an x-ray as a basic screening. Now, I know x-ray doesn't rule out malignancy, but it's the first stage. Now, if I'm a physio and I'm the first person to see somebody and I'm confident they've got a frozen shoulder, but I've got to wait 6 weeks to get an x-ray, but I can get an injection tomorrow, if they basically fit all the criteria, they're the right age, they've got risk factors, they've got the right clinical picture, pain location, aggravating and easing factors, I think as a clinician that's used to seeing shoulders, you can justify doing the injection because they fit the clinical picture. And then an x-ray is, I think, less urgent in that particular group. And there was a lovely study done by Roberts et al. In 2019, where they essentially looked at over 350 patients referred with frozen shoulder. The clinicians basically did their examination and their subjective history, and they said, these are the patients we think are frozen shoulder. These are the patients I'd want an x-ray. There were only 8 patients that had abnormal x-rays, and they were the 8 patients the clinicians had said, I'd want an x-ray. So what this study showed is if the clinical picture fits and you're confident, then actually an x-ray probably isn't essential. The issue we have in the UK is that our pathways generally say you can't diagnose it without a normal x-ray. So we've kind of got evidence saying one thing, we've got pathways necessitating another thing. And I guess my key message is, I have to x-ray if I want to do an injection or an intervention. The key thing is if features fit, then it's good. But as soon as they don't fit, then you need that imaging to back up your clinical diagnosis in the frozen shoulder population because of that relative risk. And as I say, the problem is an x-ray, you need 30% destruction of the bone before you'll see anything on the x-ray. So if you are suspicious and there are things that are worrying you, MRI is by far the most sensitive to then look for malignancy or early avascular necrosis, etc.
Okay. And now moving on to the shoulder irritability that you mentioned about the tendinopathies and all of those. Any tips on how to diagnose them and then how to manage them?
Yeah, so again, your subjective is absolutely your friend. If you listen out for the clues, then this is where I guess I always think it's interesting that on social media, if you do the whole X-ray for frozen shoulder debate, everybody gets all excited and one group say you must, the other group saying, oh, if you diagnose well enough. And to me, it's very similar with acute shoulder presentations that might be irritable. So to diagnose a reactive tendinopathy, I want to hear the patient tell me a clear change in loading history. That's like fundamental for me to make that diagnosis. Somebody with an acute reactive calcific tendinopathy has to tell me they woke up in the early hours of the morning with acute onset pain, which is very mechanical and reproducible with resisted tests. Lots of people will have calcium on X-ray, but that doesn't mean that's related to their symptoms. It's only if they wake up in the early hours, and it's generally a 30 to 50-year-old age group. And again, often metabolic factors can be a risk issue. Developing frozen shoulder, we've already talked about some of the things that would give me a clue. And then we have less common pathologies, things like Parsonage-Turner, which is a kind of autoimmune issue where they often wake up in the early hours of the morning, but unlike a calcific tendinopathy, which is very local to the shoulder and very mechanical, in a Parsonage-Turner, it's upper quadrant pain, they develop weakness. So again, that history of onset, where their pain is and how it behaves together is really useful in signposting those different pathologies.
Okay, and then on the management, would you manage them with load? How would you go about treating them?
Yeah, so when I look at patients who come to me with shoulder pain, I have some kind of non-negotiables that I think are important. And of course, all this is underpinned by my education. And I believe my symptom modification is part of my education and challenging negative beliefs. So educating through movement, not just through our words and what we say to patients. But in terms of what I actually do in my head, they've come to help with pain. So I want to look at things that are going to help potentially modify their pain. Exercise is always central to what I do and will be based on their symptom modification if I'm able to change it. But in my head, what I'm trying to achieve is make life easier for the shoulder. So unload it, if you like, to get some sound foundations, and then reload it to make sure they've got the functional capacity to do what they need to do. So I kind of, as part of my assessment, I look at symptom modification, but I also use a test where I assess assess the arm in prone and look at their passive rotation and then their ability to do that actively. And most patients with shoulder pain won't be able to do that, but if you support the weight of the arm, they can do it. And I think this through range and this rotation reflect what we currently understand about the cuff, the scapula, and the muscle function around the shoulder. And they're simple objective things I can retest to assess the value of my exercises. So generally they'll do something through range, something to target that rotational role of the cuff, generally with the arm supported. But then how I progress will be very dependent on what the patient wants to get back to. So I kind of believe those foundations give the patients the confidence to move and stop trying to protect their shoulder. I make sure the cuff and scapula have the capacity to do their job, and then really it's build on it in a functionally relevant way.
Okay, and what are the improvement tests? I saw you performing them. It was very interesting. So what are the tests and how they guide your treatment?
So again, if a patient comes into me and they say, oh, this movement is painful, then, so let's say elevation's the problem. I think there's a lot of contention about why symptom modification works. But in my head, I want to make life easier for the shoulder. So I can immediately make it easier by unloading it. So I would just get them to bend their elbow and try and repeat the movement. But I generally get them to make a fist, because we know if you make a fist, it just upregulates the cuff. It just gets everything ready for action because your brain thinks you're going to move your shoulder. Now, it could just be I'm getting them to start the movement in a different way, and it could just be unloading. So there's lots of things that potentially allow it to have a positive effect. So I've unloaded it. If that doesn't make a difference, the next thing I'll do is add some resistance at the back of the wrist. Now, we have evidence showing that just upregulates the posterior cuff. In elevation, the posterior cuff should be working harder. So that's my rationale. But again, the fact I'm giving them a resistance to work against, it's reinforcing selective movement. And again, maybe just getting them to start the movement differently. But if I do that and it makes the pain better, I can just give them an exercise that replicates that by giving them a loop of TheraBand that does the same thing. If that doesn't change it, then I'd go on to a scapular assistance test. And we still have a lot of experts out there that say if you do a scapular assistance test and it makes their pain better, you should do scapular-based exercises. I don't necessarily agree with that. I think when you put your hands on the scapula and make it move better, you're giving tactile input, you're unloading the shoulder. Again, all it means to me is I'm going to put a bit of TheraBand around the back, or I'm going to get them to lean against the wall with a loop around their wrist, so that whatever changed their pain in the clinic becomes the exercise, their first foundation exercise. And again, they'll do that through range. If none of those things work, then the final thing I'd do is add in the kinetic chain. Again, if you initiate your upper limb movement with a step up, whatever, again, it probably reinforces normal movement. We know it makes it easier to facilitate local recruitment in the shoulder. It reduces compensatory strategies. Again, it's just another way of getting them to move differently. So I think we can argue and debate the potential, what we're doing with that symptom modification. But to me, it's a way of empowering the patient to feel confident and realize actually their shoulder can move quite well with a lot less pain if they just do it in a different way. That informs my first exercise, and those are the most common things I use. The only thing I haven't mentioned there is compression, and certainly in instability and people with really grumpy tendons, sometimes compression is the thing that makes the biggest difference. So I would literally just give some compression kind of through the elbow or through the forearm up into the glenoid before they start. And again, if that makes the difference, then I'm going to add that into their exercise and make compression a key feature of their through range exercise.
Okay, so when you bend the elbow to do like the elevation, the flexion, right? So you are putting less load, or the levers less,
Yeah.
right? So that would guide your treatment to like try to remove the load at first to give a chance for the muscles to work properly. What's the rationale?
Yeah, I think if you look at the common theme in people with pain, for some reason some people get stuck in patterns of protection, which just make life harder for the shoulder. And so then they just get stuck in this pattern. So in terms of unloading, if I achieve that with a symptom modification exercise, that becomes my unloading exercise. If it's somebody who they can't do the exercise, then you're absolutely right. I could just unload it more. I could support the arm on the wall doing the same exercise on a gym ball. I could sit at a table and support it on the table, or I could even support it with the other arm as they push into the wall. So you're absolutely right. If I can use my symptom modification exercise, that's where I'll start. But in some of those really irritable patients we talked about, sometimes they need to go even further back and have even more unloading to find where to start. But that movement is really important to just desensitize the tissue, make life easier. And so we kind of reteach non-protective strategies, I guess.
And then when you add the resistance to the hand, right, when you're doing the shoulder flexion, does that tell you that you need to work on like firing those muscles more, like just like the pattern of activation versus like maybe being weak or something like that?
Yeah, so again, I think I keep saying you're asking great questions because you are, but I think again, it just highlights some of the debate we have in the literature at the moment. So we have a lot of experts and researchers who get very excited if we start talking about muscle recruitment and activation patterns and muscles being switched on or switched off. We have evidence from people like Ann Cools that if I get somebody to do an exercise against the wall with a loop of TheraBand, with the arm supported, it changes their recruitment pattern. Now, there's a huge heterogeneity in how people move. So I think, as I said with the symptom modification, my rationale is I'm biasing the posterior cuff. But what I'm looking for is a change in symptoms. So I think there's lots of potential mechanisms, some of which we don't understand. If I'm honest, I probably do still think about influencing the muscle system, but I'm also thinking about that loading aspect. And the shoulder loves attention. It's a bit of a sensory monster. So just giving it sensory input, whether that's resistance or a visual target, whatever, all those things have the potential to change how people are moving. And it makes them more fluent and less protective, which again potentially translates into a reduction in pain and an increase in confidence.
Okay. And like on the scapula, so when you're assisting the scapula to move better, right? And they do improve, and you say like, okay, that's very passive. We don't want to be doing that. But would you think about potentially the muscles around the scapula rotator cuff are not working properly to make it do the movements that should be doing while they're elevating their arm, and then therefore would work more on those muscles? Would that be a
So
fair?
again, I think all the things you're asking really highlight kind of how our understanding of shoulder pain and dysfunction have changed over the last few years. So we've realized the limitations of scapular assessment, and unless you've got fancy lab-based, our in-clinic measures aren't really that useful, and dyskinesia is really common in people without pain and who never have pain. So there are still experts that will say if you do a scapular assistance test and it changes their symptoms, you should do a scapular-based exercise. But when we look at muscle function, the cuff and the scapular muscles are partners in crime. They kind of work together with the other shoulder muscles all the time. And there's just a change in bias according to if somebody's got pain or they're scared of moving, etc. So the other thing I would say is if you look at what are called scapular exercises, because of the attachment of the cuff to the scapula, you can't separate the two things. So my bias is not to isolate muscles, it's to give them that sound foundation of confident movement, make sure that basically they can do their rotation with the weight of the arm, which targets the scapula and the cuff, and then to reload in a way that's functionally relevant to them. So the times I would be much more specific about muscle weakness is if somebody's had a nerve injury and the muscle's recovering, if somebody's had a muscle tear, if they've been immobilized for a period of time, or somebody going to high load activity where once they've got those foundations and they've got pain-free movement through range, I might look at specific muscle testing to target strength deficits. But in my normal non-traumatic subacromial pain population, I don't think that specificity is helpful. It's more about that confident movement, which potentially is changing their recruitment strategy and making sure they've got the capacity to do the thing they want to do.
So do you think it's more about the recruitment than the weakness per se, or the way that they are firing the muscles?
So again, I'm conscious of using words like activation and recruitment patterns. And I'll be absolutely honest, that was absolutely what informed my practice in the early days. I think it's just as we look at emerging evidence, we're probably having other effects as well. But my bias, because I see lots of people who failed from doing lots of strengthening, is if you strengthen on the background of a compensatory strategy or protective strategy, you limit your threshold for improvement. So my bias is to establish an efficient foundation, and that may well reflect efficient recruitment. So I'm not unnecessarily generating intrinsic overload of my system. I establish that foundation and then strengthen in a way that's relevant to that patient or load up.
Yeah, okay. I just did a webinar series this weekend about the shoulder, so I have everything fresh on my head. That's how I'm asking so many questions. I was looking at the movement system from like Shirley Sarman, and a lot of new concepts in my head. So that's how I was asking. Now I start thinking a lot more about the movement pattern and all that stuff. So that's how I'm asking that I got the idea of the sensory motor coordination and activation patterns and all of that a lot more than like strengthening per se.
Absolutely. I love that. And I think it comes back to the shoulder being a bit of a sensory animal. It's like, if, you know, it's an obvious place to compensate. We know people wear tension in their shoulders. And I think it's, again, if you don't reinforce that, exactly what you've said, that neuromuscular element, then everything you're doing is on a background of inefficiency or protection. And people like Shirley Sarman have done an amazing job of kind of highlighting things we need to consider. But I think what's interesting is where we see we can change those things with simple symptom modification rather than very isolated specific exercises. And potentially it's more empowering for the patient because they see that change much more quickly.
Yes, very good. And I remember seeing that she said that 80% of shoulder issues are caused because of rotator cuff not function properly, right? So what do you mean by that? The same thing that we are discussing here, those like the movements, the activation, what they should be doing when you're moving your shoulder?
So the reason, so that quote comes really based on the experts who, when they look at the prevalence of shoulder pain in the general population, they will generally say 70 to 80% of what we see is related to the rotator cuff. Now, it's a little bit of a contradiction when you think, we said earlier that the structure doesn't matter, but the premise is that if somebody comes to you with non-traumatic shoulder pain, targeting the muscles of the shoulder is probably one of the most useful interventions that we have at the moment. It doesn't have any particular risk. It's not necessarily, we have studies emerging saying just educate patients, maybe we don't need to do the exercise, but if we're going to do exercise, what seems to be most supported is specific to the shoulder, targeting the cuff and scapula and making it functionally relevant. So really, when I quoted as saying that, is to say, look, the vast majority of what we see is non-traumatic shoulder pain. It will respond to simple principles of getting people moving more confidently and then loading them in a functionally relevant way if it's meaningful to the patient and they see the link to what they want to do. And it's really to kind of say to clinicians, shoulder often gets press as being really complicated and really difficult, and people have been taught really nuanced movement assessments that are no longer supported in the evidence. And so it's really to empower clinicians that, look, these key ingredients can be applied in the majority of patients as long as it's meaningful and done in a way that's meaningful to them.
And what would be examples of functional movements that you would use, just to clarify? Because when you think about rotator cuff, we learn at school those external rotation, internal rotation with the TheraBand. So just to help us visualize it, how would you use functional movements involving the rotator cuff?
So again, I think you highlight a really important thing there. So we generally, if you look at the evidence or you even type in Google cuff exercises, you're absolutely right. The first thing you'll see rotation exercises, but the cuff has, equal distribution of type 1 and 2 fibers. So it's a stabilizer and a mobilizer. And that through range that we're talking about, those kind of through range foundation exercises, the cuff works through elevation. The anterior cuff works through extension, and it's only really in abduction that cuff truly co-contracts. So I'm aware of that. So if I'm doing through range elevation, that's the stability role. If I'm doing rotation, that's the mobilizer or torque production role. So I will do those basic exercises, but then progress it into what the patient wants to do. But again, if I look at somebody early in their rehab, doing external rotation in neutral, we know that a lot of patients will not really get their cuff going because they're set to protect. The nearer we can get them to abduction, and if we support the weight of the arm, then we make it all about the cuff and the scapula. So I generally will start them with supported rotation work. And then when they can do that with a weight, I always say 5% of body weight. That's just because it's the weight of the arm. But fundamentally, from doing those other things we talked about, you'll often find that prone test we talked about improves quite quickly. And then I'm going to do loading relevant to what they want to do. So a simple progression might be external rotation, elevation through range with external rotation resistance. But then I want to know, what do they want to do? And I might just use the same direction of resistance to just bias what worked in their symptom modification. Does that make sense?
Yeah. And then like the external rotation with abduction, would that be more functional? That's why you're using it versus using down?
So when I'm thinking of those kind of non-negotiable foundations, if we look at the research of people like Karen Jin, the bottom line is, if I work in that position, I'm maximally targeting the cuff with the scapula doing its stability role. So in terms of giving that patient all the ingredients to then translate into the thing they want to do, it makes me confident that they've got those.
Okay, it makes sense. And now about the kinetic chain. I know you're a big fan of adding those exercises. So, and I remember seeing you saying about the contralateral glute being essential to fire the shoulder muscle. So would you talk more about how important is adding that kinetic chain to the exercises?
Yeah, so again, it's not essential, but it just makes rehab easier for patients. So if you think the shoulder very rarely functions in isolation, if you reach into a cupboard, there's a normal pattern of activation through your lower quadrant and your trunk that allows to do that. But it's probably no surprise that most of the evidence has come from the sporting populations, because again, force output at the shoulder is massively influenced by force generation from the lower quadrant, and then that rotational transfer of force through the system. So again, if I see athletes, a previous lower limb history might make me think this could be the reason their shoulder's not getting better, because their force transfer is inefficient. But in terms of rehab and symptom modification, we have evidence that shows us if we initiate our shoulder exercise with a step up, any form of weight transfer, it just makes it easier to get local recruitment of the scapula and the cuff muscles, but it also has an unloading effect on the shoulder because you reduce those compensations. So you gave that example of if I work the opposite glutes, then I reduce lats on the affected side, and we now have a couple of studies that support that. So if I do a step up or a step forward as I lift my arm up, because I'm working my glutes, it seems to reduce the compensation on the other side. But again, I think we have to be cautious about these very structure, muscle, recruitment specific explanations, because I'm also getting the patient to start the movement in a different way. It's got more momentum, so I'm going to reinforce transfer in an easier way. And we have studies showing that a kind of global exercise like that just lights up more of the cortex. So again, maybe it just makes it easier for the patient to get out of those protective strategies. So lots of potential mechanisms, but I just think it makes rehab easier for patients.
Yeah. And is that something that you commonly add to like all patients, or you especially just for the ones that respond to the how do you call the movements that they get better with the step up, like you're testing the shoulder flexion and then you are transferring weight to the other leg? If they respond to that, then you add those strategies, or do you use that with most patients?
Again, if they're very irritable or they've had a long history, those are the groups that I'm more likely to use it all the time, because I just think I'm doing everything I can to make it as easy as possible for the shoulder. So in the very acute, I'm looking at unloading it as much as I can, and I think the kinetic chain helps with that. In the people who've had symptoms for a long time and they've just got stuck in a rut of a protective strategy, I want to make it as dynamic and sensory rich as possible. So again, I think the kinetic chain does that. So I'll still go through the symptom modification, but what you'll often find with those two patient groups is when they start doing the symptom modification exercise, they can only do a few reps and it feels hard, or they don't get the same effect as when you did it. And so if you add the kinetic chain, immediately they can do more reps, they feel more confident, and it doesn't feel as hard. So it's part of making the exercise work for them.
Okay. And that compression that you mentioned, that you add for the patient's instability or tendinopathy, why do you have an explanation? Why does that help?
Well, we do have evidence that compression is really proprioceptive for the shoulder, and it's a great way of getting that initial ready for action. So the upregulation you see in response to a task in the cuff and the scapular muscles, as long as it doesn't hurt. So to me, it's just influencing that muscle system in a way that allows the shoulder to move without protecting. So if compression worked, then again, it's coming up with an exercise that works it through range. So I have a real favorite where I get patients over a gym ball with a loop of TheraBand around their wrists again, and they just basically roll back and then pull the knees up to their chest. So basically doing elevation through range, but with compression. So again, it's to inform that initial exercise, but again, when we look at adherence, if patients see an exercise relates to what changed their pain, they're far more likely to do it if we can change their pain. I know we can't with everybody, but if we can, then it's a great way of fostering adherence, but also building that confidence.
Okay. And I am McKenzie trained and I've done Mulligan, so I can help to ask. We have some classifications like derangement, right? So we see like very quick symptom modification with specific directions. And like in your opinion, with your experience, what would that be? Would that be the 20% that are not related to rotator cuff? How do you see that? Is that like more, articular something, or just a motor sensor? Like, what is your view about that quick change that we see with some patients?
Yeah, so I think if you look at McKenzie and you look at the cervical spine, that can be an actual real bonus in shoulder patients. So we have evidence that people who have no evidence of neck involvement, so full range of movement, no palpation findings, etc., you do repeated movements, a third of patients you'll improve their shoulder pain because you're modifying the neural supply. So I think with McKenzie and repeated movements of the neck, they're well proven in having a positive effect in the shoulder, because I think it just modulates neural input. That's my rationale. So you're having a direct input on pain, but we also know that repeated movements in the neck can influence cuff recruitment. So if you're really struggling to do anything else, why wouldn't you? You know, it's a potential strategy, and the same with your manual therapy. I think in terms of repeated movements at the shoulder, again, it depends on the presentation. I'm always thinking in terms of, a bit like you said before, is it just the way they're moving? Is it the fact they haven't got enough capacity? Is it because they're scared, or is it because they've got an injury? So there's a nerve injury, a muscle tear, etc. You know, really simple things. So these derangements and things, I think, are less supported in the shoulder, but there's no doubt that you can still affect. We've seen the videos on YouTube of repeated hand behind back or extension and things to improve movement. But maybe we're just desensitizing with repeated movement rather than that kind of derangement model. But what I do like, and I think has some increasing support, is the mobilizations with movement. Because again, if you think, we said the shoulder light sensory input, if I put a bit of band over their shoulder or a bit of band around their back to reinforce the movement I'm trying to achieve, I'm giving them an added sensory input. So I think it's less about the biomechanics, but more about the confidence and the sensory input that we give to patients. And another foot, and let's not be honest, I've described my approach to symptom modification, but Mackenzie and Mulligan's are other approaches to symptom modification. And to me, as long as they foster an active approach, things the patient can do rather than I have to do, then I'm not going to argue with you.
Yeah, it's quite crazy, like a few patients that if you move them one direction, their range of motion improve, their strength improve, and then you move them on the opposite direction and they get obstruct.
Yeah.
Yeah.
And that's fascinating, isn't it? And whether it's neural, whether it's the patient, whether it's what you're changing about, who knows? But I think the important thing is if you do it and it changes it, what does that mean to my prescription and what am I going to give the patient to do?
Yeah. And I know you're running out of time. So quick question about resources of information. Anything you recommend people to go look for if they want to find more relevant information for shoulder?
Yeah. So I've been involved in a couple of textbooks recently. Frozen Shoulder that was edited by Philip Stroif, and the Shoulder Theory and Practice that was edited by Jeremy Lewis and Cesar Fernandez de la Penas. If you don't want to spend any money, I've done loads of free resources on Facebook. So if you type in Jo Gibson podcast or Facebook and any shoulder topic, I have done probably 80 and they're on every subject you can think of: instability, long-headed biceps, complex patients, weird and wonderful pathologies, and they're all free and you can access them as much as you want. So I'm a great believer in trying to help clinicians, because I see some really weird stuff just because I see a lot of patients that have failed, and it's great to share that so that people are aware of it and maybe they'll then see it in a patient too. So yeah, I definitely signpost people to that.
Yeah, you do have a lot of videos out there on YouTube. I myself watch many of those before our conversation. And any advice to clinicians that are starting their careers?
So the two key pieces of advice would be, make sure you hone your communication skills, because communication is your superpower and the success to everything that we do. And the second thing would be keep open and keep reflecting, because you're never certain. And so, you know, I think you have to be really careful being very about one way of treating people. It's having a variety of tools that help different people. And that's what makes our job so fun, is that you're always learning and you're always reflecting.
Very good. And if people want to find more about you, you already told the Facebook, any other way they can connect with you?
Yeah, 100%. I'm on Twitter and Instagram with a very uncool moniker of @ShoulderGeek1. And I have online courses. I have an online course with Clinical Edge, but I also have an online course with the Adjuncts ABP, who are a French company, but have translated my course into French, Italian, and Spanish. So again, hopefully making it accessible to as many people as possible.
You just need to translate it to Portuguese now for the Brazilians.
Okay, I'll have a word. I'll make sure that's next on their list.
Oh, Jo, thank you so much for your time. I learned a lot. I appreciate you coming here and sharing your knowledge. Thank you so much.
Thank you so much for the invitation and your fantastic questions. You got me thinking.